All right. So this is today caring for patients with chronic pain and opioid dependence. And Craig is a friend of ours from near the Sioux Falls area at Sanford Health. So we're really excited to have him. He volunteered for this talk. We didn't twist his arm at all. Next slide, please. So some announcements. Remember, there's a new echo format coming, right?
Right.
Do you know anything about iEcho?
No, I'm avoiding it.
Oh, okay. Well, we're not, and we're trying to get everybody to sign up for iEcho. And we're actually going to do a quick poll. The best reason to register for iEcho, which we really went for last week.
Does your IQ increase?
Your IQ increases by a minimum of 10 points if you do.
And you get a Nobel Peace Prize?
Within 5 years. And in fact, your house mortgage will be paid off shortly after registration, or all the cool kids are doing it like Katie. So you pick what you think is the right answer, and we'll do that poll.
Wow. I think I might do this now. I mean, we were going to wait till the first of the year, but the sooner your house mortgage gets paid off, the best.
Yep. And so it turns out all the cool kids are doing it like Katie. So perfect. Thanks, Katie. So we actually have a next slide. Signing up. This is a little thing that we're doing to try and get you to interest to re-sign up, and it's a big push at Echo. So next slide, please. As you can see, I'm not the most computer savvy guy, and so I was signing up, and we took pictures while I signed up. And so I said, time to sign up for iEcho. This can't be too hard.
Not hard at all. I had it done in a jiffy.
Next slide. It didn't go as well as I planned, but I knew what to do, and I have a rotary phone. So that is hooked to Katie's rotary phone. And Katie was not helpful.
Seriously, Kurt?
Yeah. So my nurse stepped in, and in 1 minute and 9 seconds, she got signed up for iEcho. So trust me, it's very quick.
But you're still not signed up. She's signed up.
She signed me up. So I'm signed up. So yeah, and we are aware that there's some people having problems. We're talking to the Echo people here today, kind of to try and figure that all out. So next slide. A lot of upcoming Echo sessions. Next week, of course, the most famous of all the Echo speakers, Charlie Resnikoff, is coming on, and he gives potentially the best talks other than Craig of everybody we know. So make sure you come for that one. Should be a fun talk for him. Honestly, I forget what he's talking about, but it doesn't matter. It's always great.
And there's free CME.
Yeah.
Yeah. Click your stop video button if you want to stop your video or start your video. Is that what you wanted me to say?
Kind of.
You can't say that yourself.
I'm going to just do it again because it wasn't great. Hey, we'd love it if you turn on your video, because Craig wants to see your face, and it makes it much more exciting and fun for all of us. So, and especially Craig. So we'll move to Craig, and we'll let you introduce yourself. Craig, tell us a little bit about what you do. Oh, and just remember, if you need technical assistance, you can call us. So go ahead, Craig, take over. And if you want to share your
screen, I appreciate it. I'll share my screen here now. I think we want to go into PowerPoint mode here.
I'm not the person to ask.
Yes, let me see. Okay, now I got to. Good. Can you see the screen?
Nope.
Let me try this again. Let me try it again. I'm usually this technically challenged, but let's see. Share screen. We'll do it this way. Screen 2. This may work now. Let's see if this works.
There we go. It's coming. Yep, we see your slides perfectly.
Yay. No, good. So I'll go back to my one. Caring for patients with chronic pain and opioid dependence. Well, thanks for the invitation, Dr. Devine. It's great to be with you. As a family physician, it's just great to be with my colleagues that are doing this work in the trenches with our patients. And I just appreciate this time. What I'd like to do today, it's a little bit of a different focus. I really want us to focus on ourselves as the healthcare professionals and the patients, of course, but how do we take care of these patients? How are we influenced by them? What do we think or feel about our patients? And how do they impact us? And then how does that maybe influence the care that we provide, both individually as a team in a clinic and maybe as an institution. So I worked for Sanford Health, been a family physician for 25 years. I have no conflicts of interest. Here's my objectives, and the objectives are maybe more the questions for you. So I appreciate the answers in the chat, or if somebody wants to unmute and have conversation, I'll pause. And Dr. Devine, you can help facilitate this. I'll be the play-by-play, and you be the color commentator
Well,
as we move along.
and I do have Hawaiian help, yes.
Absolutely, I love it. I love it. So we'll discuss core values and guiding principles that influence us in how we practice. So I want to have you ask yourself, what values and principles do I bring in my own personal life to my practice? You know, we all use our value system in the work that we do, whether it's intentional or subconscious, we bring it forward. Then I want to talk about the patient with CPOD, and we like to use the term CPOD, chronic pain and drug dependence. It's a patient definition that we've used to counter the addiction label that some patients will bring into the conversation. So then the second objective would be, ask yourself the question, what helps to destigmatize the negative label of addiction in my practice? What do we do to try to destigmatize that for this patient population? And finally, introduce multidisciplinary role models to medical students in a Pillar 3 course elective that we provide to fourth-year med students at the University of South Dakota, Sanford School of Medicine. And I just ask yourself, what multidisciplinary resources are most helpful for me in my practice? And how do I utilize them? And how do we work together? So what does that look like? So having said that, I'm just going to give you a little bit of background on me. I started practice. I did my med school at USD, at the USD Medical School, did my residency at the University of Minnesota in St. Paul at what was called Bethesda Lutheran Medical Center back in the day, and graduated from that program. So it gives you kind of an idea of my age. And then I did the traveling doctor thing for a couple of years. I was married. Our oldest son was 1 month old when we started doing the locum tenens, and I worked anywhere from Soldotna, Alaska on the Kenai Peninsula to Aroostook County Medical Center in Presque Isle, Maine, the northern tip of Maine. My wife and I, we say we could write country western love songs for those 2 years we had. Worked with EPA, EPPA emergency group in the Twin Cities at Unity and Fridley, and at Mercy Medical Center up in Coon Rapids. So I really appreciate the time. Then I came to my hometown in Sioux Falls and started doing practice. And this was one of the things we saw as the drug reps would come our way. It said, aren't opioid pain medications like OxyContin tablets addicting? Even my family is concerned about this. And as you can see, the narrative there is, you know what? You focus on the pain and not really worry about the addiction. In this situation, it should not be a problem. Well, these are some of the advertisements that were given at that time. I had the privilege in the 1990s to be the medical advisor to the HPAP program, the PHP, that took care of physicians, nurses, dentists, pharmacists in recovery from addictions. And many of them were addicted to opioids and benzodiazepines. So I had this sense that I'm not sure this is always the greatest thing to have. And yet here's what sat on our counters, literally back in the 1990s. As you can see here, it says expiration October 1999. That's 7.5 milligrams of hydrocodone with 200 milligrams of ibuprofen. And as you can see, it was a Schedule 3 back in those days, hydrocodone was. And that's an actual sample right there of a tablet that we used to get free as samples to distribute to whoever we wanted to. So interesting. Then, of course, let's fast forward to the 2020s. And now the DEA just seized over 375 million deadly doses of fentanyl in 2022. And as we can see, we're going to focus on that patient population today that comes into that clinic and they're on opioids and they're also suffering from chronic pain. And you inherited them. They were seeing somebody else, they're on opioids, they have chronic pain, and now they're in your office and you have resumed their care. You can see that the synthetic opioids tends to be the fentanyl, and the semi-synthetic drugs that you can see, which is the darker green, That's responsible for 25% of all opioid overdose related deaths. Those are the ones that are coming from our prescriptions in our offices. So discuss core values. This kind of started when Dr. Devine and I were discussing what trust might mean in a practice. And so I was in the same clinic for 25 years, and for the first 20 years, I had the same nurse. And we learned early on a mantra, and I find the guiding principles to have in your office are always healthy. And so my nurse and I developed this mantra, and our mantra was, we are only as good as how well we take care of the patient we like the least. And there were times my nurse, busy clinic day, she'd say, Dr. You hold it, pause, stop, take a deep breath. What's our motto? Remember our motto. And so we found every person deserves to be treated with respect. Now, again, it's gotten to the point where sometimes it's a safety issue, short of it being a physical safety issue for you and your and the people that work with you. Everybody needs to be shown respect and dignity. And so we just made that a point as it is not the patient's job to understand me or my team. It is our job to understand the patient. And that's what this is about. For the last 5 years of my practice, my nurse retired. I had a younger nurse, and she said, Dr. Youthy, when you come into the office in the morning as the physician, you're kind of like in charge of the dimmer switch in the office. If you come in, you're having a good day, it's pretty bright. Well, if you don't, and I said, do you want me to leave and come back in? No, I'm just saying, you have a significant impact on what happens to our team in the day. I also say, well, it could be am I going to bring in fragrance or am I going to bring in stink?
Craig, do you follow the Vikings at all? I'm wondering if that has anything to do with your mood.
We put fluoxetine 5 milligrams in the water in Sioux Falls. We think it helps. But yes, I am a Vikings fan. So having said that, what are your core values personally? What are your core values as a clinic, as a team? Here's some of the core values you might find that you use. And so with that, is there one that you relate to? Or put in the chat, what would be some core values that you bring into the work that you do? Very interested to know what those things might be. For us, trust is a big one. And with trust, I was introduced to a book about a year and a half ago. I do quite a bit of executive coaching. And in a group of executive coaches that are not in medicine, they kept talking about this thin book of trust by Charles Feltman. And it's just an outstanding resource for you. And he says, there are 4 components to trust. What are they? What do you think 4 components of trust are? The first one, I always talk to med students. I say, you're going to the 4th year med students, you're going to graduate in a month. And in 3 months, you're going to open up that clinic door. You're going to walk into that room. That patient's going to be sitting there and they are trusting you. And you're going, if they only knew, right? They trust you for one reason, and a very, very valid, well-deserved reason. You have a degree behind your name. You have competence. They will give you the benefit of the doubt. They will trust you. That is the great accomplishment that you are given by the patient when you go into your practice. The problem is you now have to maintain it. And so Charles Feldman says competence is actually the second most important factor in trust. He says the number 1 factor in trust is caring. And as the saying goes, no one cares what you know until they know that you care. Well, I've had patients, well, Dr. Youthy, boy, I know he says he cares about me, but he didn't even look at me during the entire visit. He was looking at the computer screen the entire visit. He says he cares about me, but I'm just not seeing it. A third component is sincerity. And it's not what I think, it's what the patient is seeing. Perception is reality. Am I aware of how I am conducting myself to that patient? Do I look like and be trustworthy? And then finally, boy, I'd sure trust Dr. Youthy, but you know what? He's always a half hour late. I don't know if I can rely on Dr. Youthy. I think I may have to go see somebody else. I can't trust him. So as you can see, there's multiple components to trust, and we take this very seriously, and we try to instill these 4 components in our practice when we're doing this. I want to show you one other resource that you might want to consider. This is one of my favorite books of all time, The Ideal Team Player by Patrick Lencioni. I'm not going to get into it. We could do a whole hour on the ideal team player. But if you have hunger, if you're humble and you're smart, and I'm not meaning intelligence, you have the ingredients to be the ideal team player, something to seek out. And then finally, this is something I do in my practice. Music is medicine to the soul. I love music. We'll talk about cognitive behavioral therapy a little bit. That's something we could all do in our clinics visits, is try to provide some incentive for them to take ownership of their health. How do we do that? When this patient comes in with chronic pain, they're dependent on an opioid, life has been tough. I will give them in their after visit summary a list of songs in a YouTube playlist. And I have probably, well, my nurse would joke at me, Craig, Dr. Youthy, go listen to one of your 265 favorite songs. Chill out. I know you're 3 minutes behind, 5 minutes behind, 10 minutes behind, but you need 4 minutes just to time out, listen to a song, get the oxytocin up a little bit. You'll be fine. And so this is just an example of the playlist that I'll give, a wide variety of artists and songs. I always will include Be Kind to Yourself by Andrew Peterson in every playlist I have. And what I think they're going to hear, I say, when you come back for your visit, when you come back, what I want you to do is I want you to tell me what song you listens to and if it resonated with you and how it resonated with you. Was it the melody? Was it the music? Was it the beat? Or was it the lyrics? And I'm just amazed at what the patient will come back at. I kind of have sort of an intention as to what I think they're going to hear, what I want them to hear. And they'll come back and they took something out of it that was very different. But it's always helpful because it's their story and it's what they took out of it. But in Be Kind to Yourself, there's a phrase I love, and it goes, how does it end when the war that you're in is just you against you against you? You've got to learn to love, learn to love, learn to love the enemies too. And that phrase is identified by patients not uncommonly. There are a lot of wounded patients in our practice, and they are not only guilty, they're very shameful. And so to get somebody to try to open up and be kind to themselves, I've had people have transformational changes by just identifying with this. Now, I don't do this alone. I get our counselors and our behavioral health teams involved too, but there's no reason why I can't plant the seed and see it start to germinate in my clinic practice. So again, what values do you instill in your practice? What's your mantra? What are your tools? Now we used in our clinic practice, and I'll state here, I left my clinic practice after 25 years to go into more physician support, coaching, be the physician's physician at Sanford Health. I became addiction certified through the ASAM back in 2000. And in that same year, I went and became certified in something called the Myers-Briggs, the MBTI. And then 10 years later, I became certified in a personality profile called the Hogan Assessment. And if you have the opportunity to grow and develop self-awareness and just your emotional intelligence through some personality assessments, I highly encourage you to do that. I moved from my practice over to the Sanford Chronic Pain Clinic. And I have learned over that time that trust may not be the value I need so much as I need respect. And the story is, about 6 months ago, I was getting ready to go into one of the patient rooms, and the nurse just is shaking her head, kind of side to side, no. I said, well, what's that about? And she says, I'm not sure if you're off to a very good start here. And I said, well, why not? Well, one of the patients was sitting out in the waiting room, and I went out to get her, and I overheard her say, who are you seeing today? And the patient you're seeing, Dr. Youthy, said, well, I'm seeing Dr. Youthy. And the other patient looked at her and said, oh, that's too bad. You're not going to get what you want. I thought, this is not like my 25 years in my family practice clinic. So trust was not necessarily, I mean, that's always a goal of mine, But I found respect. I need to respect this patient, and how do I develop respect for this patient when I try to get them to see that what they want may not be what they need. And if you have some ideas, put it in the chat, because I'm all ears and all eyes. I want to learn from you. I don't have an answer to that. It's just a challenge I have with this patient population. But I will have medical students oftentimes with me, and I'll say, now, if I use the word addiction, please let me know. I try to go through this without using the word addiction. Even if I want somebody to see a licensed addiction counselor, I will say, I want you to see somebody that's licensed in providing care for people with opioid dependence. But it's not uncommon for the patient at the end of the visit to say, Dr. Youth, are you calling me an addict? Well, what we found is the patient is always going to see what they want to see. This is a picture I took at the Badlands of South Dakota earlier this summer. There's a sign that says beware rattlesnakes. And of course, there are no doubt there's rattlesnakes in there. Well, if the patient thinks they're going to hear the word addiction, they're going to hear the word addiction. So what do we do about that? We started using the term CPOD. We said, well, we want to talk about the condition you have. You have chronic pain and you're dependent on opioids. And so you have chronic pain opioid. So we like to call that CPOD. They might say, well, I'm not a smoker. Say COPD, but this is a chronic illness, which is similar to the illness of COPD. And so we want to help you with this illness that is something that you don't necessarily have control over. You can't get rid of it. It's a condition you have. And it has three components: pain, it has a dependence to the opioid, and there's a good chance there may be a mental health component. So from a chronic pain standpoint, for our definition, and I'm going to run through these slides fairly quickly. I present these to our med students who take a course elective with us. We talk about chronic pain as lasting for 3 to 6 months. We use 3 months at Sanford. One of the reasons is because that's what insurance companies will use when it comes to qualifying for reimbursement and testing, that type of thing. But I love the definition given by the American Chronic Pain Association. They say chronic pain or persistent pain is pain that continues when it should not. It's so ambiguous, but it's so true. It's just hard to define it. Then there's the 3 types. There's nociceptive pain, which is tissue pain. It's the pain we have with our bone, tissues, muscle. There's neuropathic pain, which is pain of the nerves themselves, the nervous system. And then sensory hypersensitivity pain, you can call it what it wants. It ends up being our fibromyalgia, our interstitial cystitis, our irritable bowel syndrome, all those more evasive, nondescript definitions we have. And then I do like the 3 tiers of the schematic representation of the pain metrics. There's the nociceptive response. I cut my finger off and I have this immediate pain. Tier 2 is my perceptive, intentional. I look down and my finger is gone. It adds a new dimension to my pain now. And then there's the 3rd tier. That's the pain I'm feeling maybe a week, a month, 6 months later. That's the pain we're dealing with in the chronic pain clinic. So what do we do with this? What about the drug dependence? Well, again, we talked about the semi-synthetic opioids, hydrocodone, hydromorphone, oxycodone. These are the meds that we're prescribing that are contributing to the misuse and abuse of drugs. So how do we make sure we're using them the correct way? Morphine, codeine are the natural opioids. And then you can see as our synthetics, the fentanyl, tramadol, methadone are some of the synthetic drugs. I do like to use conversion tables. They're not the greatest. I don't use them as a sound black and white boundary, but they are very helpful. And talking about medications and MME is valuable for risk. How do we know what risk is? Trying to define a number is not necessarily the best way to do it, but we do always use the conversions. This is the one that we use most commonly at Sanford. There is some variations, but then we actually put together, here's the brand names. These are the 4 most common codeines that opioids that we use in our system, along with morphine, and it usually comes in as morphine SR or MSIR or MS Contin. And then you see the MME potency of each drug at that dosage. When it comes to codeine elixir, Just note that 2 tablespoons is approximately 9 MMEs. And if a person's a hyper metabolizer, ultra metabolizer, they're adds at risk for rapid metabolization. And so if you're using a liquid suspension with children, the black label warning is something that I always like to kind of emphasize when it comes to codeine elixir. A lot of people are getting codeine cough medicine prescriptions to contribute to the misuse. And then I just want to emphasize the DSM-5 to give us how we define it. I find that approximately 25% of the time, the opioid dependence will be listed in the problem list. 75% is probably not accurately listed. And if a patient is taking their opioid exactly the way their doctor's prescribing it, if I give my patient oxycodone 10 milligrams 4 times a day, and they're taking exactly the way I want them to take it, they're getting 60 MMEs per day, always call in and get it at the same time, never take it and need an early refill. That would only be called opioid dependence. And so that is what we use for the term for their for the OD part, the opioid dependence. It's pure opioid dependence. No misuse, no abuse. Well, what about substance use disorders? What about opioid use disorder? Well, we look at the DSM-5 criteria and the 11 criteria there. And what we see is if a patient has any of these other symptoms other than tolerance or withdrawal, 10 and 11, now they have an opioid use disorder. And we look at the first 4 as being impaired control criteria, the next 3 being social problems that are related to their opioid use continuously. 8 and 9 are related to risky use when it puts them in a danger or they continue using even though it's harmful. And by doing this, we can look at mild, moderate, or severe. So when that patient calls up 2 or 3 times and says, gosh, I need an early refill, Dr. Youthy, they tend to be taking the substance in larger amounts. And oftentimes they're having cravings and urges, spending a lot of time. I would say the majority of patients I see are not opioid dependent. They're probably opioid use disorder mild. And then we have a conversation as I present this to them in a very objective fashion saying, this is CPOD that you have. It's a mild form. Let's make sure we are looking at your risks and benefits all the time when we do this work. What about the term addiction? Well, a substance use disorder severe is synonymous with having an addiction. So internally, we use that because now we start talking about, is it the pain that we're controlling or is it the opioid dependence we should be focusing on? And when it comes to addiction, there is no reasoning behind it. It is the amygdala hijack. It is the midbrain hijack. And there's always going to be drug-seeking use and harmful consequences. And it should be addressed formally with the patient in all instances. So what do? Patients with pain and drug dependence have a co-occurring mental illness over 50% of the time. When we have patients come in, we say, what are the 3 components? Are they addressed in the problem list? And are we providing the comprehensive care that they should have? We always want to say pain's going to be there all the time. Matter of fact, the patient will probably come in and say, I'm here for my pain recheck. They're dependent on the opioid if they've been on it for more than 3 months is the definition that we use for drug dependence in our organization. And over 50% of the time, they're going to have a mental health diagnosis such as anxiety, depression, PTSD, ADD, ADHD, something's going to be in there. And so we ask to pay a close attention to the very first thing the patient states about their CPOD in their visit. And so that ends up being, hi, Dr. Youthy. I say, what brings you in today? Oh my goodness, I ran out of my pills 4 days early. I need a refill of my OxyContin 10 milligrams 4 a day. Not cutting it. We're going to have to increase it. Yeah. And how's your pain? Oh yeah, I'm hurt all over. As opposed to a patient comes in and says, I say, what brings you in today? Oh, Dr. Youthy, man, my pain, it's no longer just my feet from my peripheral neuropathy. My whole body aches. It just aches. And I'm thinking I need to maybe increase my opioids. You see the difference in the patient's presenting emphasis for what they're in for? So I was asking myself, why is this patient really here today? Are we really dealing with pain? Or is that a distraction so that I'm not addressing what might be an opioid use disorder? And this would be really the part that I should be focusing on, something to take into consideration. One thing that's been very helpful at Sanford, we use Epic, and we have a dot phrase in the plan. We brought this into our chronic pain clinic about 2 years ago, and this just helped us to be very directed in every time, what are we doing for their physical pain? What's our outcome goal? What do we need to do? What's our timeline for reviewing it? How about their opioid dependence? Let's look at their medications. What's the risk benefit of them? What are the benefits they're receiving? What are the risks? So what are we going to prescribe this next time? What are we considering that's not an opioid? What's our goal and what's our timeline for reviewing? And then we do the same thing for the mental health component. It just is a very good way to check for that patient with CPOD each and every time. So one of the challenges that we have in our system now is we have all these chronic pain patients, many who we've inherited, who are opioid dependent. They have chronic pain. We want to adequately treat that pain, but we don't want to deny an opioid use disorder. If we have a patient who needs pain relief, but we're finding that the risk outweighs the benefit of their opioid, and in general, we're going to say 50 MMEs per day as a general guideline for that. Now do we bring in buprenorphine? And are we talking about an MOUD type of an experience? How do we take this from moving from a MAT clinic and disseminating it through all of our primary care clinics so that we have our primary care providers thinking differently? I should be prescribing buprenorphine in my practice. What does that look like? Do I put the diagnosis and attribute the problem to their opioid use disorder? Or do I attribute it to their pain? It may make a difference in their reimbursement, but I want to focus on the real thing that we're treating here. Buprenorphine 3 times a day is a very good pain reliever. Buprenorphine once a day can be very, very good if it's a craving or an urgency the patient's experiencing that they call pain. That's a very general oversight of my experience in how patients respond to buprenorphine. That could be a whole hour discussion right there in itself. And then Butrans, we use it frequently in chronic pain, but do we want to use the generic buprenorphine in a Subutex or Suboxone fashion in our treatment? And then, oh, by the way, there's the whole issue of acute pain. And this is just hard to wrap our heads around. The MMEs per day and the MMEs total in prescription, when we're talking about the patient with CPOD, and no, I'm not calling you an addict when I say CPOD, we're talking about getting under 90 MMEs per day in some recommendations for a level to shoot for. When it comes to acute pain, it is recommended from, this is the work that was done by ICSI over the years in Minnesota in association and in cooperation with the Minnesota DHS, and just want to give that group just great accolades. I was able to be part of that group. Great discussions, great evidence-based recommendations out of that. And from that, we recommend less than 100 MMEs total in a prescription when a patient comes in, like with a distal fibular fracture. What? 10 milligram hydrocodones or 5 10 milligram hydrocodones? And even for post-operative pain, patient comes in, they have an open reduction internal fixation of a fractured ankle, and they go home with 100 or maybe 200 MMEs. It depends on which tier you might recommend. That's all that is thought to be required from what we've seen for early refills, that type of thing in that situation. So what we do is we provide our physicians with this sheet right here that gives you actually the amount of MMEs total that would be at 100 or under 100 in a prescription for 2 commonly prescribed drugs. I remember the first time I heard somebody say, well, we only recommend 100 MMEs total for this acute pain. What went through my mind, and here I am, I've got all these years of experience taking care of this patient population. I'm going, I think that speaker just misspoke. I think they're talking about 100 MMEs per day for 3 days, not 100 MMEs to be distributed over 3 days. This patient, we're talking about 100 MMEs per day. And it took me about 15 minutes, and I finally realized I better go do my search in the literature, because they're actually saying no more than 100 MMEs in the total prescription. So there's some challenges that go with that. So again, CPOD, we found that to be effective. I encourage that term to be used. I feel that it's helpful for my colleagues who might feel hesitant to treat a patient with a buprenorphine in a long-term setting. But I think by using the CPOD label, it actually provides my colleagues and myself, let's treat this like we do COPD. Let's treat it like we do diabetes. Yes, my real fragile type 1 diabetics, I'm going to refer to endocrinology, but I can still be part of that management team. How do we want to treat the patient with CPOD? Okay. Then I'm just going to talk about a course that we provide to our 4th-year medical students. It's a 2-week elective. It's called Chronic Pain and Drug Dependence, and they spend 2 5-day work weeks with us. So it's 20 different half-day experiences that they get. And in that, they actually get to go to a chronic pain clinic to see what medical management is like in there. They spend a half a day or a full day with acupuncture from an Eastern medicine training perspective, time in a pain anesthesia clinic that might be procedure oriented. They go to the Sioux Falls Treatment Center, which is a for-profit methadone clinic here in Sioux Falls. Spend time in OCMed, which is also a place that we really like to have them spend time, because then they get a chance to do a lot of look at the urine drug screening, medical review officer for what does urine drug screening look like in this type of work we do. And then if there's a work-related injury, how does an injury at work in that tier 3 reasoning of pain that we have weeks to months after the injury, what does that look like when it's work-related as opposed to home-related or not work-related? Again, chronic pain clinic, med management, again, different settings. Integrative care, inpatient. So we do have them work with our integrative care team. They provide aromatherapies. They'll do acupressure. You'll see all kinds of different methods there. They go to a chiropractic clinic. The Sioux Falls Family Practice Residency has an MAT clinic, MOUD clinic, multidisciplinary, great experience. Time with hospice. Obviously, treating pain with opioids in a hospice setting is very different in other settings. So we like to have just that half a day. And in this course, they're 4th-year med students. Yeah, we want them to know the MMEs. We spend a lot of time helping them get the training they want for the medical management of patients, converting from IM to PO to IV medications. But we really want the students to focus on the impact the patient has on the team that's caring for them, and how that clinician and that team treats that patient as they come into the office from the time they register to the time they leave. Get on the balcony. How are they being treated as humans? And what kind of impact does that patient have on that team? Spend time with a CBT counselor, Western medicine, acupuncture, palliative care. And then we offer them the Hogan Assessment personality profile. So I provide that to them. And then we do a simulated lab patient with an expert screening, brief intervention, referral treatment for addiction. And we actually have patients who are difficult patients, who are manipulative patients. They're simulated patients. And we have the student do a recorded visit in a very challenging setting. It's quite intimidating for the med students. They say they don't sleep the night before they're going to have this visit, but after it's done, they said, what a great experience. The pushback I get when a patient starts crying, or the pushback a patient states when, if you're not going to give me my pain meds, then I'm going to go out and hurt myself or else use street drugs. How do you as a clinician respond to that? And so a great learning experience for our students in that environment. With that, I'm going to give you a few resources that I find highly valuable in the work that we do. Scopeofpain.org comes out of Boston University. Dr. Dan Alford, I believe is his name, is the internist that oversees that. You can get CME credit here that applies to your 8 hours that are required for your DEA renewal when you get to it. Highly encourage you to do that. They just came out with a Scope of Pain 2.5 hours of CME credit that is focused on the Native American population. I did watch it live, wonderful resource. And then PCSSnow.org, they actually have the 8-hour training session that you can take. There's one that's for physicians, there's one that's for PAs, and there's one that's for nurse practitioners. And it's an online 8-hour bupe training session. It goes way beyond buprenorphine training. It's outstanding. There's one that's directed to pediatric buprenorphine training. So again, I think it meets the needs of many, many prescribers. At Sanford, I'm overseeing the DEA renewal process for us, and I get a lot of individual requests. I find this one is probably the one that I recommend as a primary resource. And of course, I recommend this 1-hour CME that Dr. Devine provides as being a great resource to get the hours that are required also for the 8 hours when you renew your DEA. Finally, what other educational resources are available for CPOD? CurableHealth.com. I encourage everyone to get signed up for that. If you're not signed up for that, wonderful tool, just a wonderful tool. You have a place to sign up as a clinician. And then when you give that website to the patient, you can actually enter the patient's name. And there are free resources and there's resources you can get for a fee. I find the free resources are oftentimes enough to jumpstart that patient. Anytime you have a pictorial, I use pictorials all the time. I do like Dr. Ming Kao's pictures that he has. You can see that one with the opioid alternatives. The red side has the risk factors. The green side has other options you can do for treating chronic pain. So I like to just show that to the patient and say, what jumps out at you in this picture? I don't want to tell them what they should be looking at. I want to know what they're seeing and then respond to that. And you learn a lot about the patient when you ask them what they're seeing instead of me telling them what they're doing. That just gives me another tool that I share with the people, and I use myself all the time. I call it the 4 options that I have. So write on a piece of paper the word invite. Under the word invite, write the word encourage. Under the word encourage, write the word challenge. And under the word challenge, write the word tell. And now put a line between challenge and tell. And whenever I catch myself telling the patient what to do, I stop talking. And I sit back and I go, okay, I don't like to be told what to do. I like to be informed. I like to be an informant. But how do I now rephrase that so I inform them? Does this patient need an invitation? Do I need to encourage this patient? Or does this patient need a kick in the pants? That's the art of medicine. And I find that just that very, very, very simple word image for me is very, very helpful. Again, some books. Unlearn Your Pain is a great book. There's Better Choices, Better Health. Sanford has used this. It's opportunities that are available. I know across the Siouxland, and our Great Plains region. So that better living with a healthy life and chronic pain, a lot of good resources there. So I encourage that. Our behavioral health, I do as much of this as I can with my behavioral health colleagues. They're as valuable as my pain anesthesiologists are, and my other supportive medical treatment team players. Finally, I'm going to end here and then open it for conversation. We've received a grant at the University of South Dakota Sanford School of Medicine to provide Hogan coaching. Again, it's a personality profile that basically identifies our blind spots, or what we call our derailers. We all are going to respond behaviorally to a patient. Okay. Remember I said we are only as good as how well we take care of the patient we like the least. That's because I get emotional and I may act emotionally to that patient. And my nurse is going, Dr. Youthy, I know you don't want to do that. So pause, know what your derailers are. You've had somebody coach you. You've had a Hogan coach. You know better. Your job is to understand them not to understand you. So now that you've had coaching, in this program, we had 30 students have the opportunity to do patient simulation, virtual and in person, patient interviews of somebody that's screened positive for addiction as they define it. And so then the simulated patient will respond in different ways that's meant to try to stir up behavior and derail the student. And it's an incredible experience. The students love it and the students hate it. And they get a certificate of completion after they finish it. What we have found, so I'm Hogan Assessment certified, and through the grant, we were able to get 5 other clinical faculty members Hogan Assessment certified. So now we have a team of 6 executive coaches regarding Hogan Assessment coaching. And what we found is our students are now coming back to us because they did it in some of their preclinical education. Some are doing it in the throes of their Pillar 2 clinic experience. But what we're finding now is the 4th-year students are coming back to us saying, we did the Hogan when we were 2nd-year students, and now I'm just seeing this incredible value on how it can guide me in my career. Even though I'm not going to be doing addiction medicine, it can help me in so many ways: leadership, teamwork, my own self-care, my self-recognition, and leadership skills. So again, if you have the opportunity to benefit from something like that, I highly encourage it. Tap 33 here talks about SBIRT. And then I really like tip 35 because it's about motivational interviewing. And again, I keep going back to this all the time. I must admit, I use my own intuition most of the time. It gets me by. It seems to work. But I'm always looking for tools and for algorithms. And motivational interviewing is a great scientific way to do empathy training and patient interviewing and motivating. So you get into that pre-contemplative, contemplative, observation, action methodology with where the patient's at. Again, it's our job to understand the patient, not the patient to understand us. So I'm going to stop there, and I'll stop sharing my screen also, and let's have a conversation.
Yeah, we got about 10 minutes for some questions, and I know that Miss Hawaii has one, so we'll let her start.
I wish I were Miss Hawaii, but that was great, Craig. I really enjoyed that, and we are going to invite you to speak on our echo. Melissa says, post-operative C-section, we're only using scheduled ibuprofen and acetaminophen from date of surgery to discharge. Rarely do they need any opioids now. They're walking at 8 hours after surgery. The scheduling made all the difference and actually improved patient pain satisfaction. So that sounds right up your advice alley. But I'm wondering, we do have some patients in Hawaii who have chronic pain and they can no longer get any opioids, even though they've tried acupuncture, massage, all kinds of things. And so there's actually a movement, I don't know, an underground movement for pushing actually to have more opioids available. Our dentists don't even do opioids anymore. You can basically only get them if you go to the emergency room, and then it's only a week's worth, and it's probably more than what you recommended there. So have you heard that side of it too, that some patients cannot get opioids when they feel that's the only thing that helps them?
Yes, thanks for that statement and for that observation. First, on the C-section, it is recommended. And again, I think there are patients that do not need opioids. The general consensus right now is less than 100 or equal to 100 MMEs total. And there's a debate between the American Academy of Pediatrics and the American Society of, I want to say, anesthesia regarding OBGYN. I'm not sure what the group is. The AAP recommends using hydromorphone, Dilaudid, because it's thought to have less effect on the neonate. It's disputed by the Academy of Anesthesias related to OBGYN cases. So I'll just let you, some people say use oxycodone or hydrocodone. Another group is saying hydromorphone. My thought is as long as it's under 100 MME, I don't think either, they both make valid arguments. So just to be aware of that. I love the idea that we try to do without an opioid. Some patients will just say, I don't want to use it, okay? On the flip side, should patients be able to take opioids chronically? Yes, that's part of the art of medicine. It's that risk benefit. So at Sanford, we bring this work through peer review. And in your problem list and in your SOAP note, if you can justify your plan for pain, their opioid dependence, and their mental health, we're not going to be talking about you shouldn't be on that medicine or you shouldn't be at that dosage. I trust the maintenance of certification of my colleagues with that. And so we bring it through peer review. And if a patient and if a clinician can in their documentation provide a good plan of action, that's fine. I know I personally, back in the 90s, I commonly had patients on 5 milligrams of hydrocodone 4 times a day. And I thought, I don't want them to leave. They're asking for more. I'm not going to let them have it. I know their pain is not related to that leg injury anymore because now they have pain over their whole body. Is this actually hyperalgesia? And that's, again, another topic we could talk about for a whole hour. Am I helping this patient with their opioid? I don't think I'm hurting them with 5 milligrams of hydrocodone 4 times a day, but I'm not going to lose sleep over the risk. Very
Craig,
general statement.
one of the things, and one of my favorite talks that I've kind of come up with over the years is one on opioids in the patients as they age. And I think one of the things we always have to think about if somebody's trying to justify the opioids, literally you have to consider their age as they age. And I take a lot of patients from the pain clinic who get sent to me who have literally, I've had a patient who took 1 benzodiazepine, an older lady, and it stopped her breathing, right? She was that close to the edge. And so she went to the ER, got an Ativan, went home and fell asleep, and her daughter had to call the ambulance. And so we have to always remember too, and I think I just love this talk. I mean, I think this is so needed. And I think too that we just need to think about how people react to these as they age, because it can really, they can be teetering on the edge on the same dose they've been on for 20 years.
Well, you and I need to connect for coffee or something because we could go on and on. I'll just share one patient. I inherited a patient. Again, we always have that inherited patient. I inherited this patient who is 75 and is on 10 milligram oxycodone a day, 105 MMEs, mild renal insufficiency. And so what I did is I said, I had a med student. I said, I'm going to now for the first 3 months, we're going to stay in the same dose. I want to build up some trust or respect, but then I'm going to start tapering him. And this is, and so the student was with me at the day we're going to start tapering. I said, instead of you getting 210 pills this month, I'm going to give you 205. And I want you to make that last the 30 days. It was almost impossible for him to comprehend that. I mean, it seems reasonable, doesn't it? Okay. Long story short, he ended up going to a counselor, a farmer, retired farmer. I ended up having significant family dynamics. Three sons. A son disowned the family because of all the dynamics that went into the family farming. So as the story goes, everybody has a story. Everybody has their stuff. His stuff came out when he finally succumbed to going and seeing a counselor. His wife was an enabler to the extreme. And so, but once he was able to start getting some counseling support, he didn't like it, but he very begrudgingly let me go down by 5 pills a month. He's, and then we got down to where, around 50 MMEs. But 105 MMEs at 75 years of age with mild renal insufficiency, that's the risk benefit. I cannot justify the benefit over the risk in that. Now, did I want to just ignore it and just do the easy thing and make him like me? Yes. I just couldn't do it.
So Melissa, where did she go? Melissa, did you want to unmute and did you have a question? I couldn't tell.
No question. He was talking about hydromorphone, and we use fentanyl instead of that. And that's because of the pediatric warning for breastfeeding moms to not use codeine and codeine-like products because of respiratory suppression in neonates.
Yeah.
Are you using it as a patch, or are you using it as a perioperative?
Perioperative and in labor as well. That's typically what we use if they don't have an epidural. 85% of our patients get an epidural though.
Okay, great. Thanks for that.
Perfect. Dave, I saw you turn your camera on. You must have a question.
Well, yeah, I'm glad to hear that approach because, there's a growing body of literature that if you force people to taper, it just doesn't work. And they either leave or they go and try and find stuff on the street, or they're going to treat their pain. And I just feel like it's better for me to keep that relationship with them and keep in contact with them than to try and force them to do something. And it might, a lot of times they'll eventually come around to it, but it's not on the insurance company's timeline or mine, but it's on theirs. And usually you can get them down somewhat.
I think too, and most of the people on here are family medicine and addiction or both or whatever. And I think that it's often, I get these patients sent to me from the pain clinic, and I got to be honest, they send them over for what they consider this patient has an opioid use disorder or some big problem. And my first question is always, why do you think you were sent here? Right? Because what the reason is that the doctor sent them or the nurse practitioner may be greatly different than what they think. Right. And so having a conversation with them about their opioids, I hit on safety like 90%. I want them to understand, what the risks are, the fact that if they have COPD, their risk of stopping breathing and their all-cause mortality is super high in 2 years. And so there's just a lot of things that people don't know about the opioids, the way they affect them. And so, but I don't force people. I never do. I will give them the education, and I hope that they make the decision that I'm kind of shooting for, right? I don't know, Craig, is that similar to the path you take?
It is. I want to trust the patient. I want them to trust me. But I follow the guidelines for, signing an agreement and doing a universal drug screening. And again, I want to do it in a very formal way, and then very openly, what are the risks and benefits? And I want you to be part of that discussion. Here's my challenge with you. What do you want to do with this challenge?
Yeah. Yeah, I have.
And that sounds like a great course that you're giving your med students.
Yeah.
Because I just find too many residents come out and they're just terrified or won't use opiates for anything in any circumstance, which is probably not the right answer either.
Yeah.
And I will say hi to Sam Seltz for you, Craig.
Thank you.
Yeah, I'd love to do it for the residents too. We have family medicine residents, and I looked at your thing and I thought, we should be thinking about that.
Well, even confronting, or you don't want to think of it as confronting a patient, but even your approach to a patient who wants something so much that they're going to get angry is terrifying to a new resident. and they
Mm.
may succumb. So I think this is great for everybody because it gives the provider more confidence that they can talk about it. And it's not a yes or no question. You know, do you refill somebody's just like it was or not give them any opioids? It's not necessarily black or white.
Well, we're about out of time, Craig. You, that was a grand slam, just, you know, that was really, you know, it's just out of the box enough that it's just so interesting, your perspective, and I just really appreciate it.
It was
I
a
hope
privilege to be
back-
part of it.
Yeah, I hope you'll come back and throw another one of these at us. It was, I think, well received by everybody. So,
Great. Appreciate the time.
yeah, well, thank you so much. That was great. All right, everybody, next week, Charlie Resnikoff. I don't know if he can do as well as Craig. I'm gonna point that out to him next week, that there's a higher bar now. So thanks again, and please sign up for iEcho. If there's any questions, please get hold of Katie. She pretty much knows everything. I know nothing about iEcho, so please reach out to her. And have a good week and a good weekend.